All right, so today I'm talking about how to do a molar root canal in 2 hours and a crown and my methodology for that. What I'm currently doing, what's working for me, what's not working. And today I recorded this case with the CinVivo HDR camera setup. It's wireless, it's super slick. Pretty happy with it. I was just demoing it. I didn't buy it yet, but wanted to show you guys so you could see what it's like for dentistry. It's usually used in general surgery. And so it's kind of like the Synoptic that I did a video on a little while ago, but in general, way more impressed with the CinVivo just from the workability standpoint. And also we didn't really have any technical glitches. I thought it worked pretty well. It's not, you know, maybe there's a couple things like that I'll mention in the video that we needed to work on, but in general, great product. I think it could really work for dentistry. If you get motion sick easy, maybe this video is not for you. I feel like, you know, I'm moving my head back and forth a lot because as dentists, we're always like, you know, looking down, looking up, looking to the tray, looking back to the mouth, you know, looking over to grab something from our assistant. And when you have the camera, you know, attached to your head and you're whipping your head around like that, it like really, I could see people getting motion sick. I mean, I almost got like a little dizzy. I cut some of it out, but I didn't edit all that stuff out because I felt like it kind of was part of the flow of the video, if I'm being honest. So anyway, hope we can, hope it's helpful. Hope there's something helpful in this video, whether you're watching this to, you know, see what the CinVivo is all about, or if you're watching it to basically see how a general dentist does a root canal, build up, and a crown, and in this case, a gingivectomy as well. In 2 hours. This was in 2 hours flat. The patient sat down about maybe 8:05 in the chair or something like that, and they were gone by 10 o'clock. So out the door. So it was 2 hours. Typically I schedule a little longer for it just to be safe, but we were running with a little bit of a time crunch today. But it went really well. There were no complications or anything, and so let's get into it. Alrighty, so let's jump into this case. So you can see, I start out by anesthetizing. This patient deals with higher blood pressure, so I didn't want to elevate his blood pressure anymore, so we're using carbocaine here. Carbocaine's a great anesthetic, you know, and it's better than lidocaine without epi. Carbocaine has some specific properties to it that help it to stick around a little longer and give more profound anesthesia. Lidocaine requires that epinephrine to really potentiate that deep anesthesia that we get from it. You know, Septicaine, I believe, is the same way. I don't think you can really get Septicaine without epi. I mean, maybe you can. I don't know. I'm really big on shaking the cheek. See what I'm doing with my finger there? I'm really shaking his cheek a lot, because when you do that, you're kind of activating those C fibers, and you're getting, or maybe it's the delta fibers, you're activating fibers, nerve fibers that kind of help distract the brain a little bit. Versus just getting all the C fiber activation from, you know, the pain of the injection. And, you know, not that this is a super painful injection in the first place, but just a habit I've gotten into. And I'm going to give the palatal right here, little stick. I tell the patient, okay, it's going to be 3, 2, 1, and we're done, and 3, 2, 1, and done, and that's it. And I pull out. Now I'm loading another carb here. I did give a little bit of Septicaine, just a little bit, for buccal infiltration. You know that Septicaine, it really infiltrates the bone better than your other anesthetics. So I like to use a little bit of that right on the buccal, let it soak in. So I give a little bit. We're doing number 14 today. Sorry, I didn't tell you. Root canal, number 14, necrotic pulp, symptomatic apical periodontitis / acute apical abscess, and patient's been in pain for a while, so it's time to get it done. I'm amazed how people can live with this stuff. Now I'm giving a little bit of lidocaine here. I've switched out my carb and I give a little lidocaine. Now, before you prep the tooth, obviously what we like to do is take an impression so that when we make that crown, we have a stent. I don't know how many times I've gone in and started prepping. We get all done with the crown prep and I'm like, forgot to take a stent, and now I gotta, you know, use wax and kind of like build up a shell around the tooth and take an impression of that to make a stent. Kind of loading my armamentarium up, getting my rubber dam ready to go, looking at my stent, making sure it's ready. And I kind of like to go in, I'm just like, man, I love feeling the drop. So I use these flat end burrs, And there's something about it when I go in with that flat end burr, I can just, it's like I push, I just know the amount of pressure. And when I drop into that pulp chamber, I know I'm there. And I like to drop in before I even cut out any of my occlusal reduction. I don't know, it's something about seeing those cusps. I feel like I know where I am in the tooth better before I cut those cusps down, before I get that flat plane, because I do want that before I actually start instrumenting my canals. I want that flat plane so that I can have a, stable reference points for my stopper. I think that's super important for me. I really like doing that. But first I drop in, and obviously sometimes you don't drop in because the chamber is calcified. And if that's the case, you need to kind of have a feeling of like, okay, that's too far. I'm about to get in the furcation there. And that's just something that comes with experience. Over time, you drop into enough pulp chambers, you start to know what that feels like. And, in the beginning, when you're first starting out, go slow. And there's nothing wrong with having to, go in a few more times, look, see if it looks like there's color change. Is it getting dark? Are you getting down into that furcation area? It doesn't happen right away. Takes time for sure. So I'm kind of looking here. Look at this CinVivo. Look, it allows us to see in the mirror what I'm actually seeing. And albeit in this video, you'll notice it's a little out of focus. I talked to the rep. Noah was great. He was the rep who came in, and he realized that what had happened was it was focusing like maybe on the patient's lip or the rubber dam, and not in the depth of the mirror. Because if you think about it, when you look at something in a mirror, it's like that much farther away. So we should have manually adjusted the depth of focus, but we had it on autofocus. And so it was just kind of focusing on whatever the largest surface area was. So live and learn on that one. Next time, that's definitely what I would do. We tried to keep the mirror clean here for you guys so you could see, what I'm seeing. Okay, so what I'm doing here is I'm literally just removing that proximal contact, just so that I can get my rubber dam in place. Because what I noticed was that the rubber dam was not going to be able to drop down and get a good seal because of the tight contact there. So just to make it easier, I was like, let's just take this out, and that way we can see the decay. And I'm not going to prep into the gums a bunch because I don't want to get a bunch of heme right now. We'll deal with that later towards the end. So now we're getting that rubber dam. It is sitting on the gums there, so that's about as far down as it's going to be able to go. But we're gonna use some cool dam, get that sealed up nice and tight. And so my occlusal reduction is done. I used to do this thing where when I first got out of school, I would prep the buccal and the palatal aspect as well. And then that just makes it harder for your rubber dam clamp to stay on. So don't do that. Save that for the end. And so, okay, I'm getting it nice and dry. I'm kind of looking at it. And here I go with some cool dam. We're just flowing that in there all the way down to the margin on the proximal box. I mean, another way to do this is you could do a full buildup. I see that guy, the I Love the Pulp guy on YouTube. He likes to do the composite matrix, like a Garrison or a Paladin in there, and sectional matrix, build it up with flowable, and it takes several minutes. It's just usually I'm not in a hurry, but I'm trying to go quickly, and he's obviously at a point. I've got this sped up, by the way. This is like 3x speed, so don't worry, I'm not actually going that fast, but I was using a Muntzber there. Checking our working links here. Okay, how do I do this? I use my apex locator, and I go right to the working length, meaning I go until it reads 0. And I always go a little beyond, make sure it boop, solid boop. When I'm out the apex, that's when you know you're there. And then I back it up until it's like boop, 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 boop. And then I know I'm like right there at the apex. So a little bit of watch winding there, trying to get down. I'm using a 10 file. 10 file works great. I get really consistent measurements. The 10 file, I think somewhere I heard, people will say you need to use a 20 or a 15 file, but I usually use my working length. I get my working lengths with a 10 file, and I get great results. I'm not usually long or short. I'm right to the apex. And so, maybe, that's just a standard 10 file. I get mine off Dental City. Works good. Checking my working length here, and going in and just kind of doing the thing, right? Sometimes access is a little difficult. What was I saying though? Oh, so I love the pulp guy. You know, he'll build up, but this cool dam worked great. You know, we didn't really have any leakage underneath there. I did check behind the rubber dam a couple times, make sure none of our EDTA, and this is EDTA that I'm using here. My basic protocol is I use EDTA while I'm instrumenting, and I'm widening the canals and getting everything mechanically instrumented. So I'm using that as my irrigant all the way through, flushing that out, changing it out. Truthfully, I'm not putting it down, I'm not putting the little side vented probe needle down into the canals very much. My assistant's doing a lot of the EDTA flushing, and they're just getting it into the chamber, and then my instruments are helping to, you know, work it down into the canals, and it's keeping my instruments cool and keeping my instruments clean as it's working through that EDTA. So I'm doing a little bit more watch winding. It looks like I'm on the mesiobuccal of number 14 there, looking for that mesiobuccal root. We did end up finding 3 roots, a palatal, mesiobuccal, and a distobuccal. What about the MB2? Honestly, I didn't find it. I looked for it, spent quite a bit of time looking for it. I troughed right between, you know, palatal and mesiobuccal, didn't see it. So, you know, was it there? Didn't have a cone beam. Could have had a cone beam, could have taken one. I didn't in this case. Yeah, we'll follow up with the patient, see how he does, but that's gonna be my suspicion if we ever, you know, have any issues. A little bit of necrotic pulp coming off there. And see that twist in my file? After this, I went ahead and finished with my working length here, but then I threw that file away. You don't wanna mess around with files. When you see the threads of the, you know, the flutes twisted like that and straight, you know it's time to get rid of it. Because breaking files, it's just not worth it. Files are so cheap. Just grab a new one. I might go through sometimes 3 or 4 hand files, sometimes 6 or 7, 8 hand files, 10 files in a procedure like this, you know, especially for real calcified. This case was not real calcified. I thought it might be. I warned the patient ahead of time, hey man, like, you know, these might be calcified, we might have issues, but in this case we didn't. I'm back with the Munspur, and we're getting everything cleaned out here, getting down, just getting the decay out of the pulp chamber, making sure we're all the way down to the pulpal floor. We're unroofed all the way around the edges, so that's little, like, you know, your cavo surface is up here, right? Your access, and if you have any little ledges, you want to get all that opened up, straight line access, get it all clean. So we're doing that. Back with the tin file, 25 millimeter tin file. I rarely will work with a 21 millimeter tin file. I feel like it's just always too short, pretty much always. So put a little bend in it there. The reason is that little bend can sometimes help you kind of find your way out the apex. You know, sometimes it's like the apical constriction is kind of like off to the side or something. You got to like drop through it. So I guess I was doing that there. This was literally today, and I guess I've already forgotten. I was trying to remember what the measurements were, but we did 2 root canals on molars today, and so I already, the numbers are mixed up in my head. You might be able to see what the lengths were. It's around 20-something-ish millimeters, kind of standard. Anyway, so we EDTA throughout the instrumenting process, right? And then at the end, I do 8 minutes of hypochlorite, just switching it out, letting it soak, instrumenting it, running it with the, you know, using my rotary instruments. Especially, I'm a Brasseler guy. This is all Brasseler stuff. I use the XP3D Shaper at 1,000 RPMs, and that is a cool file because it deforms to fit whatever space. You know, you don't have to have a round orifice. You can have an oblong orifice, and it'll whip into all those. It looks like literally looks like a flagella on a bacterium. It's like it whips around in there real fast and gets into all the little nooks and crannies. You got to have yourself instrumented to size 30 to use it, and then you use it at 1,000 RPM in their special, you know, with their setting. I forget what the torque is, I use the Brasseler Smart handpiece or whatever. Works good. But yeah, instrument to size 30 to use it, and then it will instrument all the way up to size 60, potentially, they say. But in this case, I think I went up to size, I think I got up to size 40 on these canals, if I'm not mistaken. We'll see here. So I've got my files here. Those are all rotary instruments across the top, but a little glitch there. But yeah, in general, using this CinVivo camera, really easy. It didn't bother me at all. I thought it might be heavy, but it wasn't heavy on my head. Okay, this is the XP 3D Scout file. I'm running it at 300 RPMs, 0.6 Newton centimeters. Just to open up a little bit, I was having a little trouble getting down this mesiobuccal canal all the way. So what I did, see my assistant, see the irrigation probe there? She is flooding the chamber with some EDTA. So what I learned actually was that a lot of times your tin file is binding. It's not binding at the tip, it's binding partway up. And so you need to widen, give yourself some more room to work superiorly, kind of a crown down approach of working, and then you'll be able to get all the way to length. I think I was like 2 millimeters short, according to my, it ended up being about 2 millimeters short. And I knew I was a little short because my apex locator was showing a little short. And I use the Brasseler apex locator. I guess I'm kind of all Brasseler now. I used to be a Wave 1 Gold guy back when I worked for Heartland Dental, and that was good. I liked the Wave 1 Gold, but man, there was some cases I could not get into. And then when I worked for Monarch, they got me into the Brasseler system, the EndoSync system. And man, I've been so happy with it. I feel like I can get down to length in almost every case, and it's a little slower than the Wave 1 Gold system, but I feel like it's more predictable. And I feel like, what do I feel like? Yeah, I feel like it's just it's a very good system. So yeah, it's just, I've been happy with it. So anyhow, going down here, now when we're using the regular rotary, these are not NiTi files, these are regular, they're regular rotary files. I do have NiTi files out. That's what the second row is, in case I needed them. See the second row? But those are not reusable. Those are kind of a one and done type of thing. We thought this one might be a little torturous, so my assistant had gotten out the NiTi files for me, but we ended up using just the regular rotaries. Excuse me, the rotaries I run at 0.5 Newton centimeters at 500 RPMs, and so that's what I'm doing here. And they cut quick. They cut really quick. Once again with EDTA irrigation, and yeah, they're just a pleasure to use. So making sure I'm just going to length, I'm gauging off of the stopper there, and making sure we're going all the way to length and no farther. So like, let's say that the process, right? I go in with my tin file, and I take my tin file down until it says, oh, I'm out the apex, and I back it up until it says 0, 0. I'm right at the apex. Take it out, measure it. Let's say it says 20 millimeters. Okay, great. That's my working length. I don't really adjust back or go half a millimeter shorter or half a millimeter longer or do anything fancy. I know lots of people do lots of fancy stuff like that. I don't. And then I take my rotary file and first I'll go down with the Scout, go to that same length, and then I go to my rotary file, same length. I know a lot of people back off. I feel like somehow in my hands, maybe it's because of the way I'm using that apex locator, it ends up being like that ideal, like 0.5 millimeter short or right at the apex, rarely beyond. It happens sometimes, but it's rare, and I usually know if I'm getting beyond because my paper points are coming back with a little bit of heme at the end that just won't quit. But when they're nice and dry, like, that's usually a good indicator you're there. Also, your working length radiograph is a great indicator, of course. Excuse me. So, yeah, what I'm using here, you see that is the XP3D orifice opener. And what that's doing is that's just opening the orifices, right? We all know what that does. We just want to get it. It's not a Gates Glidden, because those always look like they're going to snap off to me. I don't know why. Or perf out the side or ledge. I don't know. So it's just an orifice opener. Works great. Got to be careful with it not to ledge or, go out the side. translate. What is that called? When you perf out, you know, you're trying to go down the canal this way, but you through the side. I forget. Anyway, going through, you know, 500 RPMs. It looks like it's doing reciprocation. It's not. The only time this will do reciprocation in this, I think it's the indistinct mode, is if it locks above 5 Newton or 0.5 Newton centimeters, then it will start going. But I'm not even engaging that much here. I'm just barely, like, if I engage a little, if it's engaging the walls, I'm getting shavings, I back out, clean it, go in again, clean it. I did some recapitulation. I do like doing that. I don't recapitulate between every single file, but I basically run through it, right? You got the 10 file, and then the Scout is basically a 15, and then I do a 20 file, and then a 30, and then a 30, no, sorry, 20, 25, 30, 35. And then I'm listening to the sounds and I'm looking at the shavings, and when I kind of hear that, you know, that like, I hear that it's taking good clean shavings and it's not mush that it's getting anymore, then that's usually when I stop. And also, then at that point we're done instrumenting that canal. But it takes some time to work up to these sizes. You know, so that was 19.5 that I just measured there. So I guess my distal buccal canal was 19.5 millimeters. But, you know, it takes some time to get everything instrumented. I do all 3 canals, obviously. I don't do one canal all the way to size and the next canal. I just, you know, if I'm working with size 25, I go all the way, you know, mesiobuccal, distal buccal, palatal. I feel like most people do it that way. Then I go up to size 30 and I go mesiobuccal, distal buccal, palatal. Try to do the same order of canals each time, because I kind of get it in my head, like, okay, I know this one's 20, I know this one's 19.5, I know this one is 20. Oh, that's what it was with this one. Yeah, it was, I think mesiobuccal was 20, distal buccal was 19.5, and palatal was 20.5. So they were all within 0.5 mil, well, you know, 2 of them were within 0.5 millimeters of the mesiobuccal. So made it easy to remember. And I double check with my assistant a ton, because I'd be like, hey, that was 19.5, right? She's like, yep, 19.5. Because I get so like, I get very like kind of in my head with this sometimes. And it's very easy to get confused and be like, I thought that was 19.5. And I've had that happen before where I, you know, over instrumented past length because I just had the wrong number in my head. So I have my assistant write it down, and then I double check with her several times. So see, I'm measuring 20.5, so this must be for the palatal. So you'll see me go into the palatal canal. I don't know what diameter this is here. It looks like it might be a size 40. It looks fairly large. Okay, I guess that was, okay, my memory obviously does not serve quite as well as I think it does, because that's obviously mesiobuccal. So, okay, anyway, it was something like that. But yeah, I find this works really good, this system for me right now. Very low failure rate, reinfection rate of my root canals currently. Check back with me in 5 years, right? That's the thing about root canals. You don't know, like, if you're having successful root canals until it's been like years later. I mean, you can tell. You take your x-ray and you're like, okay, it looks like, you know, the PDL looks good. There's no pain. There's no radiolucency. You know, that's a good sign. But I feel like it does take time to really know truly where your root canal game is at. But so far, you know, I've been using this methodology for over 2 years with good result. The 8 minutes of hypochlorite is something I introduced recently. You know, I always did hypochlorite at the end, but to be honest, I wasn't always like, you know, letting it soak in there for a full like 5 minutes at the end or anything. But the way I think about it is, okay, so here's your canal when it starts, right? And it's all full of ookie gookie dead pulp, right? And so you want to get all that dead pulp and that infected dentin out of there, of course. And then when you're done, the canal is going to be, let's say, this wide. Well, if you're spending a lot of time with hypochlorite, you know, while you're instrumenting, it's going to be doing some good for sure. But when you're as wide as you're going to be, and you remove that EDTA, that smear layer with the EDTA, and everything is clean. I know a lot of people do EDTA at the end. I understand that. This is the way I do it, because it's logical in my mind. You've got the canal as wide as it's going to be. Now use that hypochlorite to let it soak in there, let it debride, let it disinfect, let it dissolve the tissue, because obviously we have a lot of necrotic tissue that's in there. We want that all to get out of there. Frankly, like it takes time for it to dissolve. You know, it takes like 5 minutes to really start to break down that pulpal tissue that's in these little lateral canals and accessory canals and the little interwebbings that connect roots. We've seen how the anatomy of root canal spaces is. It's very complex. These are not straight tubes or pipes that we're working in. These are interlacing webs of connected, you know, so that's like, I like the XP3D shaper, it's got that curly shape to it. Here, this is hypochlorite. This is 3% hypochlorite going in here. I don't mix up my hypochlorite. I buy it at 3%. I want to let some chemical company do that for me. I don't want to be trying to be like a chemist. You know, I passed OChem, but I got through chemistry. I guess hypochlorite wouldn't be OChem, would it? It would be just Gen Chem, I guess. But I don't, it's not what I do all day, so I don't want to be doing, dilutions or whatever. I guess we do enough of that with our sedation, with our IV drugs. But anyway, see this thing? Look at this thing. It's the XP3D shaper. It's got that curly Q look. We run it at 1,000 RPMs at 1 Newton centimeter of torque. And it is a beautiful thing, except for when it snaps. Doing this, I've snapped one off in a canal and I couldn't get it out because I think it was really in there. And I think what happened was I took it all the way to length. The tip bound in the apical constriction and it snapped. And I wasn't, I use these once, I throw them away, so it wasn't fatigued. I think it was that I just had kind of over fatigued it because I was kind of using it for like almost 8 minutes straight, in and out, changing out my hypochlorite. I put the hypochlorite in, I let it soak for like 30 seconds. I carry the hypochlorite down the canal with my side vented probe, and I carefully put it down. Like, let's say my canals are 20 millimeters here. I'm not going to put my side vented probe farther than 18 millimeters at the most, carrying my hypochlorite down, because I just don't want to risk, if I accidentally bind for a moment and push a little hard or something like that, that I'm going to get some squirting, hypochlorite accident out the apex. No, thank you. I don't want to even go there. Sometimes I go much closer. So see that bend? I've put that bend in the hypochlorite needle it's probably bent at 17 millimeters, and my shortest canal is like 19.5. See, I'm looking in there, making sure I'm not getting any leakage, and sure enough, the cool dam is holding tight for us, holding solid. So it's working good. It was quick. It was quick to place, and it's functioning like it should be, keeping the area isolated and clean. So yeah, so I'm placing this hypochlorite here, putting it to length, but not to length. I shouldn't say that. I'm putting it short of length, getting it down there, and I don't know what I was looking at over there. I kind of looked over on the assistant side, I guess maybe for a number she had written down. So I'm kind of letting that flow in there. She's catching the excess. I'm looking back there because I'm paranoid about hypochlorite. It's bleach, guys. Like, it doesn't taste good. If it goes down the patient's throat, they don't want that. They don't like the taste of that. And so you can see the focus is pretty good here. It could be a little more focused on the depth of the box, the depth of the orifices, the depth of the pulpal chamber, but it's not bad. Okay, there's my paper points. We got 35s, we got 45s and 40s. 40s on the right are the black ones, 45s are in the middle. Okay, so each canal size, each canal was a different size in this case. Sometimes they're all the same size. Usually the palatal, the instrument, that one quite a bit larger. In this case, we went to 45 because it was bigger. I go until I feel like we're getting good, clean shavings. There's no prescription. There's no one blanket size fits all that every MB1 canal on a maxillary first molar is going to be a certain size. Obviously, I know you know that, but sometimes, yeah. So, okay, so going in now, and what I'm doing here is I'm still using hypochlorite. And because of that time that I broke my XP3D shaper by taking it to length, I don't do that anymore. I take it I take it to 1 millimeter short of the apex, because I don't want it binding at that apical constriction and snapping off, because it is a pretty like kind of a loosey-goosey file. Like I said, you can take that thing and bend it. It's the most flexible NiTi type file you've ever seen, which is, I love it. But anyway, I'm using my regular rotary instruments here to go all the way to apex. But here's the thing, when I have hypochlorite in the canals, I don't want to risk, like, and this is probably not a risk that we actually need to worry about, but imagine this is my canal, you know, very exaggerated. And then imagine this is my file, you know, if I push that in there and it's like a perfect tight fit, I imagine it being possible to create some pressure and push beyond the apex. Now, I know there's the flutes and the rotary, you know, the cutting thing, so it won't really like create a plug force like that, but I still don't want to mess with it. So if I've instrumented to size, you know, 40, I'm going to use a size 30 to go all the way to length at 500 RPMs, slowly advancing down the canal and slowly, you know, kind of painting up and down and allowing that hypochlorite to be worked to the apex, but not forced beyond, but but encouraged to go to the apex, right? Because what can happen is you can get airlocks, right? Because just because you introduce hypochlorite at the, you know, at the orifices or halfway down the root, that doesn't mean it's going to go all the way to the apex. And we don't want to force it to go to the apex because, I mean, we know what can happen then. But basically what I do is I just allow it, I encourage it, I invite it to come all the way down to the apex, and just very gently, right? Very gently inviting it to come down to the apex. So that's what I do. And that's what I'm doing here. And I switch out my hypochlorite in that 8-minute span. I might switch it out 3, 4, 5 times, something like that. And when I say switch it out, we just put fresh in. I don't pull back on the syringe or anything like that. We just gently flow more in. My assistant's there with the surgical suction, taking away the excess hypochlorite that we're getting down to the canals, just carefully swapping it out. And what it's doing is it's killing those bacteria, it's dissolving that tissue, it's debriding, it's opening things up, it's disinfecting, it's doing all the things that we're supposed to do in endodontics to kill bacteria, clean and shape, right? Mechanically and chemically. Debriding and getting a great substrate for preparing the way for our nice BC sealer. That's bioceramic sealer, which there's so many brands these days, but guess what brand I use? Brasseler. Why? I don't know. Because it's workable. It works nice. I've tried other BC brands. I used to mix. I used to buy Neo MTA, which you think of that as usually you use it as like a putty, right? You mix it into kind of a putty consistency and use it as like a pulp capping material, or might use it as a, I don't know, like in peds or something like that. You might use it as like a pulpotomy liner material. Like you can do it for all that stuff. But anyway, you mix it thin and you can use it as a sealer. But you know, it's so much easier to just like squeeze it out of a tube and then coat your paper points or coat your, you know, your canals. And so that's what I do. It saves so much time because we used to have to mix the powder and the liquid, and it was just this thing. And then I'd be like, oh, add more powder, add more liquid. It's too thin, it's too thick, it's too... And then I used Angelus MTA sealer. Have you seen that stuff? It's good. Nothing wrong with it. I think it has great... I've had great healing in root apexes with that stuff, but you know, it has a barrel, like it's a 2-part syringe thing, kind of like you're mixing resin modified glass ionomer or something. Excuse me, let me just check and make sure my camera's still running. You know, it's like something like that. And I'm like, why? You know, this is just the BC sealer. You literally just squeeze it out of a syringe and it's ready to go. You don't have to mix. You don't have to have a bunch of excess in a tip that you're using up like with the Angelus. It's just easy. You know, when I first got out of school, I used oh man, what is this stuff? It comes in, it's like 2 tubes. It's ribbon. Is that ribbon? Sealer? It's like all like a resiny kind of stuff, you know? I mean, it works. Nothing wrong with it. but it seems like BC sealer is becoming almost like standard of care these days. It's like if you're not, like most endodontists are using some kind of bioceramic. It's just, you know, it's 2026, guys. Bioceramic time. So yeah, just try to go with the flow. I haven't used high flow sealers. I haven't tried that. I haven't tried their ion stuff either. Brasseler's been trying to push their ion because they've got some good like internal studies they've done on it. Apparently it has more, oh boy, I forget what the specific ion is they have added to it, but apparently they're getting great results with it. You know, I'm trying to stick with, I try to change, it's relatively new. You know, it's been out for probably 5 years, I'm guessing. But to me, in the endodontic world, 5 years is like, and don't quote me on that, I could be wrong. I'm just, you know, it's something like that. So what I've done now is I've flushed with saline here. So we flushed out with saline. And we have, you know, I flush it pretty good with saline. When I'm flushing with the saline out, I take that probe with the side vented probe. I take it, that needle, I take it almost all the way to length, like maybe 1 millimeter or 2 short. Because I really want to get that hypo flushed out, you know, so I kind of start gently at the top and gently like work down, flush it all out. But what I'm doing now is I'm placing paper points. We're going to get everything nice and dry, make sure there's no weepiness from any of these canals, make sure everything is really clean and ready for that sealer to flow and stick to the walls. Because obviously if there's these are the walls of your canal that you've prepared, and there's moisture in there, you know, like how do you expect that BC sealer to adapt? Well, truthfully, it's such great stuff, it probably will anyways, but I want to make it easy for it to and give it the best chance, so I try to get things dry. I know we all do this, but I'm just saying, this is what's going through my mind, right? We're trying to think biologically here. We're trying to think biomechanically, whatever, you know, biomimicry. We're trying to be biologic. But I'm not a biologic dentist, but I try to think in biologic terms, you know. Am I a biologic dentist? I don't know. What would that mean? You hear about that. I'm a biologic. If people sometimes come to me and say, well, I was going to a biologic dentist, I'd be like, oh, like I feel like I'm a biologic dentist, right? Because I took biology class in school. No, sorry. Okay. Yeah, so we're cleaning. I'm still seeing a little bit of heme on these paper points. So I'm like, okay, not quite done here. We're getting a little like that serous fluid that's a little orangey red looking. So we're not quite clean yet, obviously. So we got to keep cleaning. And we basically go in and just keep putting those paper points in. Sometimes you do a little pumping action with those paper points, kind of push it down, pull it up, and you'll see that the tip is starting to get dry. Now, you know you're there when you take that paper point and you put the end of it against your mirror and it doesn't buckle. It just stays more stiff. Because if there's any moisture there, it'll buckle a little bit, and that's when you know that it's still wet. So anyway, we're doing a little bit of cleaning here. Just continuing to, drying, and just getting everything all cleaned out. So yeah, I mean, these are root canals, you know, they can be unpredictable. See, I have it written there. That's my mesial buckle right there. So I guess the mesial buckle was the size 35 paper point or gutta percha, because we instrumented to that length. We're measuring, and you know, so yeah, sometimes you can do root canals and you get them done quicker than you think, and sometimes things just don't get dry. Sometimes you have trouble finding instrumenting out your canals, you know, you have trouble like getting to length, you have trouble finding the canals in the first place because they're calcified or in unusual locations, or there's pulp chambers, or the pulp chamber is like, you know, calcified, or there is sclerosis, or pulp stones. There's so many things, you know. So I usually kind of have a conversation with the patient up front. I'm like, hey, listen, I'm not a specialist. I do root canals all the time. Most of them go really well, and patients are happy to be able to get it done in-house. But sometimes we have to send you out, and that's okay. You know, I got a great specialist I work with, and they will take great care of you if we need to. And obviously, if I start the root canal and I can't finish it, we're not charging the patient for the, you know, the full, we're not charging them anything for it. We're just, you know, send them out the door temporize it, send them out the door. So don't be afraid to get in there, and as long as you've informed your patient of the challenges that you expect, as well as the fact that, you know, root canals can be unpredictable, and patients understand that, you know, and they're happy. So while I'm measuring this this gutta percha here, I want to say something, unless I see something that I feel like I need to mention. So what I'm doing is I'm cone fitting here, making sure it goes to length, and it looks pretty good there. It looks like I'm pretty happy with the length. Bouncing all over the place. This is what I'm talking about with the motion sickness thing. It's like, woo. I did stabilize some of the video, but not all of it. Okay, I was gonna say something though about root canals. I see a lot of stuff these days about root canals being terrible for you, and root canals being, you know, they're gonna kill you, they're gonna cause cancer, they're gonna cause autoimmune disease, they're gonna cause, you know, heart disease and all these things. Here's the thing, you know, the whole premise seems to be that, you know, why would you keep a dead tooth in the body? Because it's like you wouldn't leave any other dead organ in the body, right? Well, here's the thing. There's bacteria in our mouths all the time, right? There's bacteria in our gingival crevices. There's bacteria up against our gums. There's bacteria living on the surface of our tongue and our, you know, in our GI. We have so many bacteria. And you say, well, those aren't the bad bacteria. Yeah, we have bad bacteria in our mouth. Even, you know, those of us who brush and floss and water pick and clean and try to get everything, like, we got bad bacteria, okay? And does some of that bacteria enter the bloodstream from the crevicular space, from the periodontal pocket? Absolutely. Absolutely they do. Now, dead teeth, do we get 100% of the bacteria out when we root canal teeth? No, we don't. And do some of those bacteria, are they allowed to leach out of the root canal space into the bone? Potentially, yes. Potentially some of that can happen. I was just thinking about, you know, we extract so many teeth at our office that, you know, we could actually do a really good study of extracted teeth and see what kind of, you know, rate of you know, infection there is. You know, we could culture it and, you know, send it off for culture and sensitivity and find out what's there. You know, also just, you know, I'm sure it's been done, but it's always good to reproduce studies, you know. So anyway, just had that thought. But yeah, sorry, it's getting a little late here tonight, so I guess I'm yawning. But you see, I'm still just, as you can see, doing the paper points, and I go through a lot of paper points. I want to make sure it's dry. You know, you spend a lot of time. This is why root canals can take time. Sometimes you spend almost no time doing this process, and sometimes you spend a lot of time and you don't really know what it's going to be. But I could tell we were going to get it. You know, we were getting them dry. So if it just won't stop weeping, then we got to temporize and send the patient home. And that actually happened this very afternoon. I wasn't able to get the distal canal dry. It just kept welling up with this, you know, serous fluid. And I said, you know what? We're going to temporize this, send this patient home. So here we go. So we've cone fitted. I know my cones are the right shape. I got tug back. I've got good length on them, you know, and I'm going in with BC sealer. See, my assistant had dispensed it onto the spatula, and I'm going in with that BC sealer, replace it down the canal, take it out. Now I'm going, this other canal is the distal buccal canal is a size 40. So I'm using a size 40 paper point, coating that. You know, I'm being liberal with it. I'm very liberal with my placement here with my my sealer, because the way I do it, I'm not going to get extrusion. So there I go, down the distal buccal canal. There we go, lining up, and down the canal. And there we go. Yeah, see that? And then a couple little pumping actions, nothing crazy. Going all the way to length though. You know, if it was 20 millimeter, I think that one was 20.5. I'm going 20.5 with my paper point, all the way to length. Now I got my size 45. I'm going to do the palatal. I'm measuring it. Looks like I want, what do I want? I want 20.5. I thought it was 20.5 for that one. Yeah, 20.5. See, I'm just like, oh, I bent it. 20.5. Yep. 20.5. Load up some sealer, a nice BC sealer. Oh yeah, that looks good. Okay. Load it up and down the hatch. Here we go. Get the mirror, roll it into place, and try not to touch the sides like I did there. Do I disinfect my gutta percha, you're asking? I often don't. I need to start. I often don't, guys. I just feel like it's, because then I'm worried about that hypochlorite coating it. Then I want to rinse that hypochlorite off. So something I need to start doing, not currently doing it. Yes, to answer that question that you're wondering. So these gutta percha have not been sterilized, because they don't come out of the box sterile, right? It doesn't say sterile on there. So technically we need to be sterilizing our gutta percha. So, but yeah, check back in with me. Anyway, so then I coat. This is more of a light coat because I already have a lot down the canals. And guys, I don't get a lot of extrusion. I don't get a lot of sealer puff. I'm always kind of going for that puff, and I don't get, on this case, I got a little bit on the palatal. I don't usually get a lot. I see a lot of dentists get a bit more than I do, and I feel like I would like to get a bit more than I typically do, but, you know, something I'm working on. That being said, on a mandibular, I don't really want to see anything. If I'm near the nerve, this one I did this afternoon, it was close. Well, it wasn't that close actually to the nerve, but I just never want to, I don't want to risk it. I don't want to be close, you know. On the maxillary, I'm not as concerned, but so I go down, I might tug up and down one more time, but I don't typically do a lot of pumping action with my gutta perchas. So, okay, back to the root canal thing and whether they're infecting our bodies and stuff. What I'm saying is, like, there's a lot of avenues by which bacteria are constantly entering our body and even entering our bloodstream, you know, through the gums, Porphyromonas gingivalis, Aggregatibacter actinicetum concomitans, you know, what else is there? Porphyromonas, I just already said that. Fusobacterium nucleatum, I think that's another one of the bad ones that we have. Prevotella intermedia. Oh, dental school flashbacks. But we got these bacteria, right? And they're to some extent we have them. Obviously someone with a healthier mouth has probably less of the bad and more of the good. What's the good one? Reuteri. The reuteris, I think is what it is. You know, reuteri, however you say that. But those bacteria are entering our bloodstream from our periodontal pockets. They're traveling through, they're going through our heart, they're going everywhere. Like, you can't avoid it. So yeah, if you have a dead tooth, is that maybe a higher burden of bacteria? I don't know. I don't know if it's much higher, you know. I don't know if that's been well studied to see, like, I don't think it's been studied at all, to be honest. Like, how much bacteria leaches from a dead tooth, from a root canal tooth into the periodontium, really through the periodontal ligament, you know, would be the main, because what they're contending, what holistic dentists typically are contending is that if you have, I love how I'm getting a good shot of the wall there. What I'm doing is I'm heating up my, my plugger, and I'm getting ready to, you know, take that off. You say, well, why don't you have a System B? I don't know. I feel like this works really well. I've thought about getting a System B, you know, automatic heated plugger, whatever. I feel like this way is fine. Like, it does well. I am heating it in between. I think I cut, I cut each of those, you know, spliced it together. So it's not like I'm doing, I usually only sear off one gutta percha at a time, and then go heat it again until it's red hot. I get that thing red hot. Because I tell you what I hate, what I detest, is when I heat that plugger, and then in between the time when I take it off of the heated flame over to the mouth and I sear the gutta percha, somehow it like doesn't completely, like, it's not hot enough and it only partially sears it, and then I pull my whole gutta percha out of the canal. I got to get a new gutta percha, and I got to refit it, and I got to pack. It's just, I hate it. I try to keep that from happening. So I usually do, I take my time with this. Okay, so I've done that. Now I'm going with an endo plugger, and I'm pushing each individual cone straight down. Cold, vertical compaction. No lateral compaction. No accessory points here, guys. Some people do that still. Great. More power to them. I was taught in dental school to do cold lateral compaction with accessory points. You end up with this thing, the peacock shot, you know, where you have like the cone, it's like you have your master cone, and you got all these little cones stuck in there to the side, and you've squished everything in. And what I found is a lot of times when I do that, I end up pulling out my master cone because my gloopy, you know, sealer in there, and your spreader, your endo spreader gets stuck, and you're trying to come out, and you pull the whole thing out, and you got this wad of, it looks like quills sticking on your nightmare. So vertical cold lateral, or vertical cold compaction. This is what most specialists are doing these days, I believe. Oh, look at that. You can see the little nubs. You sear that off. You want to get that, guys, let me tell you. You want to get that sealed off, seared off, right flush with the pulp chamber, you know, or below, at the level of the CEJ, cemento enamel junction, right? You want to get it down. Don't have your gutta perches sticking up into your pulp chamber long. I see that. Sometimes I see that. You sear it off low, and you make it flat. So it's like here's your gutta percha, you know, just like that. That pencil eraser, that should be the top of your gutta percha sitting down in the orifice, right? Say, why does it matter? No one's going to see it. Well, it matters because you see it and you know, and you can feel good. And it's like your signature. That's your signature on your root canal, that you got it nice and smooth right across the top. Because I did that. Now this is blue orifice barrier. We go in with that. Why? Because it's easy to see if you ever need to retreat. It's very easy to, you know, take your buildup out and you see the blue stuff. You're like, okay, we're almost there. I know I have about 1 millimeter of this to remove, and then we're going to be at the gutta percha. Keeps you from perfing out the bottom of your furcation, you know, because if you use tooth colored resin down there, it's going to be harder to remove. That blue is just nice. It's obvious. It's a resin modified glass ionomer type stuff, so it kind of is a little more maybe moisture friendly, tolerant, longer lasting. You don't have to bond it. You're not messing around with bond down in there. I just cure it for like 5 seconds because it's going to cure. It's self-cure. It's dual cure. It cures with light. It cures a little more. It cures completely with time. So what I'm doing here is I'm going in with my OptiBond. I love these single dose little OptiBond. You stir them up really good. It's expensive. It's probably the most expensive way to do bond, y'all. Although it's not, because here's the thing. Assistants, you got a little bottle of Scotch Bond, right? You got a little dapping dish, and you're like, hey, could you put some Scotch Bond in the dapping dish? And they're like me with the ketchup bottle, just like, you just squirt that out, and it's like, and you're looking at it, you're like, that's like $6 of Scotch Bond, you know, in this dapping dish, and you hate to say anything, and you say something, and then it gets better for a week. But you know, I get it. I was the same way. I used to work as an assistant, and I wasn't always the most conservative because I wasn't paying for it. Okay, so anyway, these little single dose vials they do. So you mix it, stir it up really good, paint it on for 20 seconds. I have my assistant look at the timer, look at the clock, and they time me. They tell me when I'm done. And then I cure it for 10 seconds and with the light, which I just did. And now I'm placing NX3, clear NX3 from Crwn. Guys, I just tell you what I use so that you know. It's not, I'm not saying you have to use it or anything. It's not like I'm sponsored or something. I'm just telling you, just so you know. Because I'm always curious when I'm watching people's videos, like, what was that? What'd you just use? Tell me. This is the Demi Plus curing light. It's my favorite. It's got the best depth of cure. I've tested it against like the Velo. This one's better. Once again, I'm just telling you because that's what I like. And I like to know what people use. So I thought you might want to know what I use. So NX3 goes in, and that's a resin cement. It's a dual cure resin cement, super duper strong. Take that rubber dam off, patient goes, oh, relief, you know. Like you can feel his face again. We got to get that little bit of blue cool dam out of there. It's stuck. So I try to poke it out with this. I don't think that works. Okay, so why am I doing this? I'm anesthetizing a little more because it's been a bit, and I know I'm going to be using the Bovie. I just use the disposable Bovies. They're expensive, $5-10 a stick. I need to get like some other option. But I've been using these so long. They're disposable. It's just easy. I've looked at lasers, haven't bought a laser yet. I don't get patients I'm getting a little ahead of myself, but I'm just telling you what I'm gonna be doing here. So I'm taking out the cool dam. That's coming up though. So back to the root canal thing while I'm taking out this cool dam. Is the root canal thing like, are root canals bad? You know, like, I don't think they're great. I don't try to do more root canals than we have to, but I think they're better than pulling teeth. You say, well, what if it causes the patient cancer or, you know, autoimmune disease or heart disease, or they have like a kidney infection because you know, left a dead tooth in their body? Well, there's no studies that say anything about that. There's been no literature, no published literature in any academic journal that has supported that. You know, there's been some documentaries, there's been some conjecture, but I was just thinking about it logically, guys. And like I said, we have bacteria in our body coming from our gums all the time. It's circulating through our bloodstream. It's not different than having a tooth that has, you know, had bacteria in it. And here's my thing. If we've sealed, you know, hermetically sealed the tip of the root. Now, what they would say is, well, there's the little lateral pores, which our teeth are, the dentin is definitely porous. I totally agree with that. You know, there's lots of, they talk about how there's miles of tubules inside of a tooth, dentinal tubules that can be infected with all this bacteria. And that's true. That's very true. The question is, to what point, to what extent can those bacteria thrive and survive with very limited fuel, right? Because when we go in and we clean the main pulp chamber out, we removed a lot of necrotic debris. To what extent can those bacteria living in the little lateral canals actually survive? Well, you know what? I'm going to test it. I'm going to get some teeth. We extract teeth. I don't try to extract a lot of teeth, but just the nature of our profession, guys, some teeth got to come out, you know? So I'm going to start saving some. We're going to put together a study. We're going to answer that question. Okay. Or if I find literature, you know, that has proven it one way or the other, otherwise, I'll get back to you guys on that. Because I think there's a lot of people that are being misled, maybe by dentists, that makes me sad if people are getting their teeth extracted and they don't need to. It's just, yeah. I was watching this video from a dentist, and he said, like, yeah, I got a tooth extracted that had been root canaled, an asymptomatic tooth. He just got it out because he's a holistic dentist, and he had done research and felt like that tooth needed to come out for his overall health. Oh, by the way, I'm prepping the Crwn now, if you couldn't tell. Flat end burr, my favorite. I use that thing for everything. These flat end burrs are my workhorse. Maybe I'll change someday, but I feel like I get the best margins. It's a coarse flat end burr. There's no bevel on the end. It's just 90 degrees. And there's something about that. I feel like for getting a margin down deep, a deep margin, it's just, you know, you're going for like a flat, like, you know, here's the axial surface of the tooth. Here's the axial wall. Like, here's the margin, gingival crevice down here. Like, I want a flat burr to get that. I run it along the tooth and it makes that flat. It's just easy. Like, I don't know. It's what I like right now. You know, we all like different stuff. So plenty of occlusal reduction. I lost my train of thought. I was talking about something related to teeth. Who would have thought? Right. So, but man, I'm watching this video back, and, you know, at first I was kind of critical of like how the feedback was, like the focus was, but I'm looking at it now and I'm actually really pretty pleased with the result, I would say, like of the footage. And I think it would be better if we had manual focused it, but that's like it's a very doable thing, you know? The way that would work is we'd have an iPad sitting there. You saw the iPad in the video earlier. The iPad sitting there, my assistant can we'd have live video feed either on the iPad, or we could have it feeding to a separate monitor so that she could closely look and be like, oh, you know, that margin he's prepping is a little out of focus. She just slides that bar over and it would take the focus like deeper or shallower and get it in focus. Not a big deal. I think that would be very doable, you know, to get everything totally adjusted. Also lighting, adding like the operatory light the overhead, the chair mounted light. I think that could also give us some better coloration, more depth. That was something that was suggested by the rep, by Noah, and I thought that was good. So anyway, guys, I want one of these. I think it's a cool product. I think it's a cool CinVivo. I gotta find I can't remember the actual like model name, but it's their latest and greatest 4K camera. It's like the only true 4K camera. Okay, I'm bringing out the Bovie, guys, now. Check it out, check it out. So Bovie's coming in. And what I'm doing here is it's got that little loop, right? And the loop gets red hot. So my assistant's suctioning, because the last thing you want is like smoke to be coming up past the patient's nose. They're like, well, what is happening? Try to suck that up. They probably are still kind of aware, but I've numbed him up, so he's not feeling anything. Numb up the palatal again too. Always numb up. I tell you what, one thing I've learned is not numbing up enough before doing this Bovie, because like maybe you numbed them up an hour ago, you're like, oh, they're still good. No, they're not going to be good. It's hot. And they're not going to post-operatively be doing too bad. They're going to be fine, but you want to make sure that I anesthetize buccal palatal again, like right before I do it, 5 minutes before I do the Bovie. You saw me doing it a few minutes ago. I was anesthetizing. And then I'll also do some like infiltration where I'll use lidocaine and I'll like get it, almost like right in the area, like into the papilla, right into the area where I'm going to be anesthetizing, just to make sure the bone itself underneath is anesthetized very well. Because you just don't want them feeling anything. It's not a pleasant feeling. Like if they're not all the way numb, they'll tell you. It's not quite as comfortable as a laser because it's hot, and it is charring, burning the tissue. It's not ablating the tissue like a CO2 laser does. I mean, that's a beautiful, yeah, I'd love to have a laser, but here's the thing with a laser. If you're going to use the laser, you got to have room in your operatory. You got to roll it in. My ops are small, guys, small operatories. I need to do an office tour. That would be so cool. That'd be fun to do an office tour, show you guys what it looks like. The building was built in the 60s. It's super, it looks like it was built in the 60s. It's small. It's not super big or advanced looking or anything like that. So I have limited space, so every time I would use if I had a Solea or a Photona or whatever, like every time I use it, I'm going to be rolling that thing in. I have a little diode laser, but it's a diode laser. All that's doing is it's literally just, that tip is just getting hot. It's no different than using a Bovie. I feel like a lot of people don't really, maybe people get that. I don't know, but it's not like a CO2 laser or like a YAG laser or a Erbidium, whatever. There's just all these different lasers out there that basically, work by just exploding, exciting the water molecules in the tissue and then just exploding the constituent base products of the, whether you're cutting dentin or enamel or bone or gingiva. It works a little differently. So, okay. Anyhow, So that's kind of that. Whenever I use the Bovie, I got to go back with the spoon excavator like I'm doing here and get those little charred bits off the edge of the margin, because they do little tags of charred tissue will kind of hang over the margin, and then the scanner picks that up and you have an imperfect scan, so I don't want that. Checking the bite, making sure there's lots of occlusal space, 1 millimeter for zirconia, guys. If you're doing Emacs, I think you need like 1.52 occlusal reduction minimum. I don't know. I don't do Emacs in the posterior hardly ever, very rarely. But yeah, I feel like there was something else I was gonna say that was kind of like maybe helpful. I keep getting distracted by looking at the flow here, and I'm just doing a little bit more reduction. I guess I saw when I had him bite together, I saw a little spot there where it's like, it might be close. I'm not even going to chance it. I'm just going to go ahead and reduce a bit more, and we're still going to be in that like probably 1.5 occlusal reduction range, and yeah, so interesting, you know. So let me know your guys' thoughts if anyone's made it this far in the video. Let me know your thoughts on the video quality, whether you think this is worth filming, or if you think it's too nauseating because of all the head movement that I do. So this is Traxident. I'm liberal with it. It's expensive stuff. It's made from Premier. No, not Premier. Sorry guys, I can't remember who makes this stuff. You know, whoever makes that stuff. Traxident is amazing. And it is, I'm just packing, I like to pack a 2x2 gauze. I open it up and then I kind of pack it down in place. This has been a couple minutes, about three to 5 minutes. Now I'm rinsing it off and it works good. Traxident works good. It just dries up that tissue. It doesn't stain like Viscostat can, or, you know, aluminum chloride or whatever that stuff is that we used to use. I really like this stuff. Because it seems like it doesn't, not only like gets rid of the heme, it also somehow shrinks the gum tissue. So it's amazing. So drying it again, making sure I can see the margin. And yeah, getting that margin nice and clean margin, that deep margin. Truthfully, he needed crown lengthening, guys. I'm not gonna lie. He needed crown lengthening on the mesial there. If we're seeing a lot of inflammation there, I'll do a crown lengthening for him later on. Just kind of adjusting, opening up on the stent. I like my margins a little wider on my temps, so just adjusting it. You can see on the scanner, that's what the scan looked like. So we already scanned, and now we're gonna get ready to dry and take a, I guess you'd say an impression. Well, use the stent to put the, you know, temporary material in. It's a 2-part, you know, 2-barrel syringe thing with the Lux. It's not Luxatemp, but it's basically that. It's a knockoff brand that I use from Dental City, my favorite place to buy stuff. So there it is. It's coming out. And guys, you know, how is it that temporary crowns always grow? Like, even if the patient's biting down on the stent or I'm pushing on it, like somehow, like, it feels like I always have to take off like 1.5 millimeters of occlusal, like I have to reduce it occlusally like 1.5 millimeters just to get the bite right, and more if I want it out of occlusion, which I take almost all my temp crowns out of occlusion. It's like, why do I want them biting on this thing that they're not even gonna have in there? You say, well, if you don't, it's gonna super erupt. Maybe a little. Tooth might super erupt a little. Sometimes they do, sometimes they don't. Sometimes it's locked in there enough with the undercuts of the adjacent teeth that it just really can't very well. And also, you know, it's only in there for a couple weeks. 2.5 to be exact. Just kind of cutting it down a little bit here. But also, I typically, like, I ask for standard occlusion, you know, on my temps or on my permanent crowns. So it's not like we're putting the bite super heavy on my permanent crowns. And if so, I'll just adjust it a little bit. A little adjustment at a delivery doesn't hurt anybody. And a little super eruption over, you know, 2.5 weeks. We're talking maybe 0.5 millimeter. Gosh, I mean, I'd be surprised if we got 1 millimeter of super eruption. If that happened, like, is that gonna hurt the patient, you know, really? I don't think it doesn't really hurt the patient. You know, the only time it could maybe hurt is if you had to like redo the crown because it super erupted so much, and then you're having to re-prep, and you prep down into the nerve space, and like, but this tooth is root canal. I just don't see that. It's not an issue. Leave your temp crowns out of occlusion. Your patients will be happier. Otherwise, they're gonna be biting on it funny. I instruct my assistants. My assistants make a lot of my temp crowns. They're great at it. I hog it a lot. I hog the job. They hate me for that. Guys, look at this. See right there? Don't use the little paper holder when you check your occlusion. You know, there's a little like articulating paper holder that comes in every operative kit. I don't use that thing. I don't even have those in the office. I use my fingers to hold it. And I'm using shim stock. I want to make sure that the shim stock on my temp doesn't drag. It just slides. It's just nothing, no touching. And I try it in a couple different spots. You know, if this is my, is this a crown? You know, this is my crown. No, that's a bad prop. This is my crown, right? I put it here, I put it here, here. I make sure it slides all the way. And then I disc it with like a medium and then a fine. I want my temp crown smooth. I heard the craziest thing one time from my, I think it was like RDO, like when I worked for Heartland, my like supervisor lady who was not a dentist, but she was a, you know, the territory manager type person. She said, don't make your temp crowns too comfortable. You want the patient to come back for their permanent. I'm like, patients come back for their permanents. Like, they don't want to be walking around at temp. Doesn't matter if it's smooth or not. If you try to make it smooth, they'll feel good. Okay, see what I'm pointing out at right here? There's a little bubble on the margin because when I put in that temporary material, it kind of like bubbled. It happens a lot. So I'm just telling my assistant, hey, when you fill that little bubble in with the non-eugenol temporary cement. You know, it's a 2-part. I buy it from Crwn. You guessed it. Yep. And I use the non-eugenol because eugenol, as we know, can interfere with, you know, bonding of resins and stuff like that. So no eugenol. We don't need eugenol. Also, it smells. So non-eugenol temporary cement. It looks like the eugenol kind, like the original temporary cement. So see, she has a little bit on the margin there. And I put that puppy in. Pop that in. I told her I'm going to push against you here. So big push here. So it's shaking so much I'm pushing. And then we let it sit for a second. And then we clean off the excess with a Shepherd's Hook Explorer. Guys, this has been great. Thank you for watching.